move to the next one, which is live. Dr. Elek, who will present the percutaneous pulmonary valve implantation in children current scenario.
We just spoke with Dr. Kosmat.
Yes.
He's connecting in a second. Can we wait for a second?
Oh yes, yeah, we can
Because
wait.
we had an emergency in the hospital.
No, yes, we can wait. Yes, sorry for that, Dr. Elek. And again, I would like to remind you to register your names if you would like to vote during the business meeting. Okay, because we will discuss about important issues. But first, you have to express your willingness to contribute to the development and promotion of the society, and for this reason, you have to be registered. Okay. Dr. Elek, again, we apologize.
Thank you very much for the invitation. My name is Miroslav Elek. I work as a pediatric cardiologist in University Children's Hospital Belgrade. And I will tell you a few words about percutaneous pulmonary valve implantation. So from the year 2000, for the past 26 years, percutaneous pulmonary valve implantation completely changed the treatment of dysfunctional RVOT. Initially, there was balloon expandable valves used for conduits and bioprothetic valves, and now we have provided larger self-expandable valves and stent constructions. So now we can treat also native and patched wider RVOTs. So at this moment, balloon expandable valves are available worldwide, but self-expandable valves are still only available regionally. So the first valve, Medtronic Melody valve, first percutaneously implanted in human in year 2000 by Dr. Philip Bonhoeffer, and that was the also first valve commercially available in the world. So Medtronic with the Melody valve standardized training program and also proctoring program, which developed also the strategy not only for Melody valve, but also for the upcoming other different valves that were designed for percutaneous implantation in pulmonary position. So the Melody valve is indicated in the dysfunctional RV2PA conduits and surgically implanted bioprothetic valves, and also if it's pre-stented for native and patched RVOTs. So the valve is bovine jugular vein, sewn in the platinum iridium stent. We have two sizes, 20 and 22 millimeters. Expanded valve, unexpanded valve is 28 and 30 millimeters height. So 22 valve can be dilated to 24 millimeters. That is the maximum diameter which can be treated with the Melody valve. So the delivery ensemble delivery system is 22 French. Valve is hand clamped on bib balloon, balloon in balloon, and it can be effectively implanted in the children even less than 20 kilos of weight. Pre-procedural imaging is very important to prevent two most important complications, the rupture of the conduit and the compression of coronary arteries. So with the pre-stenting, we can build the landing zone. It would be good to have at least 20, even better, 22 millimeters before implanting stent, because if we have a lower diameter, we will end up with a significant residual gradient, which is, we will see later, the risk factor for developing infective endocarditis. So prior Ross procedure or anomalous origin of the coronaries in tetralogy of Fallot are at the highest risk of coronary compression. They were developed different techniques during implantation of the Melody valve. For example, folded technique, so the Melody valve can be folded from one side, also from the other side. So we can have shorter valve for shorter RVOTs for early bifurcation. Also Russian doll technique. We can pull one stent, then the other stent, and so on to make the RVOT narrow, so we can implant after that Melody valve. Diabolo-shaped stent also, it is interesting technique where we can put a bigger stent and around that bigger stent, smaller stent, and when we dilate them, we get diabolo-shaped stent and a good landing zone in the middle of the stent for implanting the valve. One-step procedure is when we put the stent around the Melody valve and crimp it and implant it at the same time. Side-by-side technique, also important and interesting technique to prevent paravalvular leak. When we implant two stents side by side, in one stent we implant the Melody valve and the other stent we can close with, for example, vascular plug. Hybrid approach, it is useful in smaller children where we have problem with the vascular access. So it can be, the sheath can be implanted with the help of the surgeon, of course, can be implanted directly in pulmonary artery, and valve can be implanted in that manner. So from the year 2000, more than 18,000 implanted valves, 10-year freedom from mortality 90%, and freedom from re-intervention 60%, equal to surgically implanted bioprothetic valves. 87 survival at 10 years. Annual incidence of infective endocarditis, 1.6 in Melody and 0.5 in surgical valve. No difference in survival free of endocarditis. So bigger incidence of infective endocarditis comparing to surgical valves. Next valve, Edward Sapien valve, designed first for aortic position, first pulmonary implantation in 2006. Most often implanted Sapien 3 valve. It's bovine pericardium valve mounted on cobalt chromium frame and excellent radial strength. So it's shorter valve and it comes up to 29 millimeters diameter. This PET fabric covering is at the first place to to prevent paravalvular leak. So Novaflex and Commander delivery system, 14 French, 16 French, Sapien valve, as I said, from 19 to 29 millimeters. Large native RVOTs, transalveolar patched, and large conduits. So baseline transthoracic or transesophageal echocardiography to evaluate the heart, biventricular function, right ventricular pressures, and dysfunction of the RVOT. Also important tricuspid regurgitation. MRI and ECG-gated CT angiography to plan for imaging and to plan the procedure. Pre-stenting, it's often done, and also it is possible to crack the bioprothetic valves and to put a stent in them and then to put the Sapien valve. Because the delivery system is uncovered, we have tricuspid valve injury in 6 to 8%, but using GOR dry seal sheet, it is significantly reduce the risk of tricuspid valve injury. So results, freedom from mortality, 3 years, 98%, from reintervention, 93%, and freedom from endocarditis, 97%. No stent fractures, successful implant in 97%, and serious adverse events in 10%. Moderate to severe pulmonary regurg and maximum gradient more than 40 millimeters of mercury in 8.5%. Ideal anticoagulation and anti-aggregation therapy after implant is still different from center to center. So my valve, Merrill Life Science, is more or less the same valve as Sapien. It has more different diameters up to 32, from 20 to 32. 32 millimeters diameter can be also over-dilated and functional to 34. Python introducer sheet, 14 French. And the price is significantly lower comparing to Sapien valve. So the next valve, Medtronic Harmony valve, it's the first self-expanding valve. First that analyzed and presented the concept of self-expanding valves was again Dr. Philip Bonhoeffer, and he knew that at least half of the patients with the dysfunctional RVOT will need bigger valves. So this is again a nitinol wire frame with the PET clot valve. Leaflets are treated porcine pericardial tissue. So the diameter is first Harmony valve was 22, and the new one is 25 diameter. The length is 41 and 55 millimeters, and the proximal skirt is 41 and 54. Sorry, diameter. That's the diameter of proximal skirt. So ensemble delivery system, 25 French catheter. After deployment can be recaptured by using 26 French dry seal. So very important pre-procedural imaging and planning of the procedure, reconstruction, 3D reconstruction of RVOT. It can be virtually implanted valve to see how it fits and how much the valve can be oversized, and also can predict how the angiography images will look during the catheterization. So very important and very detailed preoperative imaging. About the results of Harmony valve, no significant perivalvular leaks, nearly complete freedom from more than mild pulmonary regurg, and no patients with mortality, with sustained ventricular tachycardia or endocarditis in short follow-up period. Several patients required stenting and redo pulmonary percutaneous valve implantation because of the intimal growth. That is also good characteristic of bigger self-expandable valves. So if we have problem with degeneration with stenosis or with regurg, we can put valve in valve. And benefits of electrophysiology studies and ablation before implantation are still controversial, and different praxis is in the different centers. After implantation of self-expandable valves, we have up to 17% of non-sustained ventricular tachycardia. And the problem is when we implant those valves, we cover the most arrhythmogenic region in RVOT. So the next device is pre-stent Altera, adaptive pre-stent for SAPIEN 3 valve. So it's remodeling the wide variety and sizes of RVOT and creating good landing zone for SAPIEN 3 valve. Nitinol frame with PET covering. Inflow and outflow diameters are 40 millimeters and central section is 27 millimeters. Good landing zone for 29 millimeters SAPIEN valve. Length is 94 millimeters and covered length is 30 millimeters. So we have distal part uncovered, and the risk of jailing pulmonary arteries, left and right, is lower in implantation of this device. It is implanted with 16 French E-sheet. It can be recaptured if it's delivered less than 50%. Altera and SAPIEN 3 valve are implanted as a single procedure in 100% of the cases. No device embolization or death at implant or in 1 year follow-up. Transient arrhythmias in 33% in 1 month, but after first month till the end of the first year, there are no significant arrhythmias. Problem is damaging of the tricuspid valve in 16% patients. Most probably secondary to chordal damages because of this open commander delivery system, but newly designed covered Edwards pulmonic delivery system should minimize the risk of tricuspid valve damage. So after implantation, improvement in pulmonary regurg fraction and right ventricular volumes, of course, and Doppler RVOT gradient is stable. No reported cases of infective endocarditis, and all patients after 1 year still had the device. The next valve, Med Zenith valve, it is created in China, self-expandable to treat native or patched RVOTs wider with bigger diameter. So nitinol wire frame covered with porcine pericardium and three leaflet porcine pericardial valves. Sizes 20, 23, and 26, and 5 frame sizes. Delivery system 21 French. So the results Implantation was successful in all patients. Acutely, no cases of embolization, malposition, coronary compression, no ventricular arrhythmias, tricuspid valve injury, or more than 2-grade pulmonary regurg or paravalvular leak. Follow-up period from 13 to 35 months. 5 patients developed grade 1 pulmonary regurg or paravalvular leak. Next valve, Pulsta valve from South Korea. It is unique, the only self-expandable valve that doesn't have that hourglass shape. Ends are 5 millimeter wider. Nitinol stent frame, porcine pericardium, cover and valve also. Diameter 18 to 28. Length 28 to 38. Delivery system 18 to 20 French, and RVOT diameter needs to be less than 28 millimeters to be so it can be treated with Pulsta valve. Successfully implanted in all enrolled patients, no major adverse events. Follow-up of 33 months, excellent outcome, no significant stenosis, see mean gradient 6.5, and no significant regurg. Mild paravalvular leak. The next valve, self-expandable venous P valve, 3-leaflet porcine pericardial valve, diameter 18 to 36, for even bigger RVOTs. So the length of straight section 25 to 30. The flares are 10 millimeters larger. Distal is uncovered. That's also important, like I said, to prevent jailing and closing of the branches of the pulmonary artery. So 28 to 30 millimeters is delivered with 22 French sheet, and 32 to 36 with 24 French sheet. So it was made for patients with native or patched wide RVOTs, more than 29 millimeters. But it needs the narrowest diameter of 32 to 34 millimeters. Successfully valve implanted and adequate remodeling of the right ventricle. From 38 patients, 1 failure to implant. Mean follow-up 25 months, no valve failures, no episode of infective endocarditis. Minor fractures, only single struts in 27%. Dry seal sheet has made the procedure much easier. And like I said, those bigger valves allow in future valve procedures even more than one time. So conclusion for pulmonary percutaneous valve implantation: initial use of balloon expandable valves, then new self-expandable valves, and pre-stents were effective in short and medium-term follow-up period. Long-term data for balloon expandable valves, survival, and freedom from re-intervention. It's completely comparable with surgically placed pulmonary valves. We see here the number of the patients in big study, 2,476. They were followed, and in 182 patients, it developed endocarditis. So a cumulative incidence of 9.5 at 5 years and 16.9 at 8 years. So it is really a problem in those balloon expandable valves. What would be the solution of this problem? To identify the risk factors. There are clear risk factors for infective endocarditis, like its residual gradient more than 15 millimeters of mercury, younger age, history of immunosuppression, and prior endocarditis. And we need to guide the future procedures and develop and design the next generation of the valves to improve outcomes of this patient population. And at the end, I want to thank you for your attention. And this slide is the summary of all available valves with the chronicle appearance and the other characteristics. So thank you very much.
Thank you so much, Dr. Elek.